All right. Good afternoon, everyone. We will get started. I'm Amanda Vikstrom. I'm the Executive Director at the Minnesota Elder Justice Center. Welcome to today's webinar. I am a white middle-aged woman with shoulder-length brown hair sitting in my home office. And today's webinar is working with older adults experiencing homelessness. And I'm really pleased to have Malia Blanchard. She's the program supervisor from the Homeless Elders Programs at Catholic Charities with us today to actually provide the information in our webinar. And we will just get started here with Malia in just a couple minutes. I just want to thank you all for joining us. For those of you that this is your first time, welcome. For those of you that are returners, we're happy to have you here. Today's webinar is sponsored in part by a grant through the Minnesota Board on Aging. The Minnesota Elder Justice Center's mission is to mobilize communities to prevent and alleviate abuse, neglect, financial exploitation of older and vulnerable adults. One of our values is committed to being an anti-racist organization and creating an environment that promotes the understanding of and the appreciation for the value of diversity, equity, inclusion, and cultural humility. And we really focus our work around public awareness, professional education, public policy work, and direct services work. And to that end, if anyone today has questions that come up in terms of for themselves or someone that they're working with where they need help or support through a situation where someone might be experiencing abuse, neglect, financial exploitation, maltreatment, you can access free confidential support with our victim services advocate who can provide information, assistance, legal advocacy, systems navigation, technical assistance. And you can reach them by calling 651-440-9312 or reach and access an advocate through our website as well. We do these webinars most Thursdays. They are free for all of you to attend. They are usually at noon. We do have a couple, we have a few upcoming ones scheduled already, and you can see our whole kind of upcoming schedule and register for our website or our webinars on our website. So if you go to our website under webinars, you will see kind of what's next and get registered for those. We do have free CEUs. They are often most of the time offered, and we are pre-approved for social work and belts. We will send out CEU information along with the PDF of the slides after the session. So you will get those sent to you within the next couple of days, along with a survey. So please fill out the evaluation. We do use those to both for funding and also to make sure that we're providing you the best education that we can, and that we're responsive to what you would like. So for today's webinar, as we dive in, everyone's on mute, but please, audience, we do welcome questions. Please use the Q&A box for speaker questions. Malia will kind of stop several times throughout and see if there are questions, and I will make sure that I'm monitoring that. So we'll get those asked or get back to you as best as possible. So please feel free to use that. Go ahead and use the chat box for other comments that are not related to questions to the speaker, to each other, or to me. Auto-generated captioning is available under live transcript, and today's webinar is being recorded. So with that, I think we are ready to begin. Malia is, like I said, the program supervisor with the Homeless Elders Program at Catholic Charities in St. Paul and Minneapolis, and I will let Malia further introduce herself and begin today's webinar.
Thank you, Amanda. Good afternoon, everybody. Thank you for joining us. I've been with Catholic Charities for about 16 years now, and I've been with the Elder Program for about the last 9 years at this point. And so far, it's my very favorite program that I've been able to work with. I love working with older adults. Today, I am coming to you from our Opportunity Center in Minneapolis, and I am a white woman with long dark hair and glasses sitting in my office with a whole bunch of client supplies behind me. So I am going to share my screen here and get a PowerPoint going for us. So we are the Homeless Elders Program. Right now, we're funded by the DHS Live Well at Home grant. Which enabled us to really start providing training to the community. We've been around for quite a while and have historically provided case management to older adults in the Twin Cities. But more recently through this grant, we've been able to also provide training for the community.
Malia, your screen is not sharing. I
Oh,
know it worked when we tested it, so we'll just.
Yeah, let me try again. There we go.
Perfect.
From the beginning. There we go. All right. Here's a list of our objectives for today. I will try my best to educate you on the broad topic of older adults experiencing homelessness, mainly in the Twin Cities, to further develop an understanding of those specific vulnerabilities and challenges that we see in working with this population. We'll talk about how our program works and a few other things Catholic Charities is doing to serve older adults experiencing homelessness, and also a few points of just some ideas and ways that we think things could be better for this population as well. So older adult homelessness is growing way too fast. It's the most quickly growing population of homeless individuals in the state of Minnesota, as well as nationally. Wilder Research does a study every 3 years of homelessness in Minnesota through personal interviews and counts with people all over the state. And I'll share with you that so every 3 years we've had the study. So we have information from 2015 and then 2018, and then we're waiting on the next round of data. So between 2009 and 2012, there was a 48% increase in people 55 and older who are homeless. And then the next 3 years, from 2012 to 2015, there was another 8% increase. We're seeing a lot of these individuals come to shelter in the Twin Cities too. So we're seeing just kind of a population explosion with our shelters, with the onset of COVID as well. And we're really seeing a lot more older adults showing up in our shelters. And of course, they just have an added vulnerability. One thing, not in addition to some of the physical and medical vulnerabilities, over half of older adults who are homeless experience homelessness for the first time after the age of 50. So these aren't people who have been living in shelters for a long time and know the resources. A lot of people that we work with really are kind of blindsided by the situation and are in shock, kind of trying to figure it all out. So that's another aspect that we see. Here's some stats about the challenges and vulnerabilities that older adults are facing from the 2018 data. So as you can see, a very high percentage have health conditions, as well as mental health, substance abuse disorder, and cognitive impairment. We're seeing a lot more people come into shelters with dementia or other memory loss. And about 90% of those individuals aren't able to work at this point. So we're really looking at fixed income as their main financial resource. And so that can be a bit of a barrier as well. Now, the cognitive impairment isn't in this number, but the physical health, mental health, and chemical health, according to the self-report data that we have, about 16% are dealing with all three of those factors. So that really makes a complex situation and makes wellness and moving forward into housing a big challenge as well. Those numbers are probably underreported as well. We know that a lot of people are dealing with, especially mental health and substance abuse, that might not report that. Wilder also looked at primary reasons for loss of housing. So you can see some of these reasons: eviction or their lease not being renewed, sometimes for a negative reason, sometimes the building's being sold or some other changes are happening where they're not able to continue living there. Rents are going up. Every year rent's going up. As we know, Social Security has stayed pretty stagnant until this year. There's a little bit more of an increase, but just rent prices make it really challenging for this population to secure and maintain housing. Loss of jobs, breakup with spouse or partner. Sometimes the death of a spouse or partner can also cause homelessness. They might have shared the rent. It might have been a family home that they lose out on if there's a death in the family. All sorts of situations come up. And then also unsafe housing. So substandard housing, situations that aren't safe because of domestic violence, instances like that as well. Then we have a list that our team came up with, just some other kind of common issues that we see. So up at the top, we've got that the building was sold. That happens often, or the building, well, either sold and they just clear out the place to kind of renovate and do repairs and up the rent, and people aren't able to afford it, or turning it into some other type of housing, which happens as well. So we have a continuous loss of that naturally occurring affordable housing. And then also we see a lot of people leave nursing homes, AMA, where they either don't like the environment, or maybe they don't feel like it's worth the cost that they have to pay from their Social Security each month once it gets to long-term care. But we definitely have people showing up at our shelters who should really be in a nursing home and can't really meet their activities of daily living. Some reasons that we see when we talk to our clients about housing loss is they might have invited someone to stay with them temporarily, and that person, they had a hard time getting them to leave. Similar situations happen with adult children who might also be in need and don't have a support system. And so their elderly parents are taking them in, and sometimes there's other behavior issues that come with that. Smoking in the unit is a common issue. Medical crises. Sometimes people will land in the hospital and not pay their rent for 2 months because they're not able to, and the support system just isn't there in place to help them through that. So we'll come across those situations too. I remember one gentleman who he had a stroke and ended up in the hospital. Just a couple days beforehand, he was working on getting that money order for the rent, and then he woke up in the hospital and ended up losing his apartment within about a month and ended up in shelter. So all kinds of things happen. Memory loss as well, just that declining function, and an increase in supportive services that aren't being addressed can also cause rent not being paid, the apartment maybe not being kept up, and can also result in loss of housing, hoarding as well. And then of course, chemical dependency, mental illness, memory loss, all those things that can kind of worsen over time and impact individuals' housing. So elders and homelessness, we want to acknowledge first that everybody ages differently, and we realize it's a different experience for everyone. But these are some of the common things that we see that are then exacerbated by not having permanent housing and really the ability to care for one's health. So the declining sensory experience, and then with it, we've got people who get their glasses stolen or their dentures stolen. You wouldn't think that dentures would get stolen, but it's happened. Hearing aids. So all those kinds of things can be hard to keep up with, hard to make sure that you have and are functional when you're staying in shelter, and might not know where you're staying day to day and have to have all your belongings with you. So that can just really be tough to keep up on that. Health is definitely negatively impacted by homelessness. If you just think about going to the doctor and getting that aftercare summary, maybe for somebody who has a few health conditions, it can be a lot to absorb and follow on your own and the comfort of your own home. But then imagine if you go to a shelter with 100 other people, and in your space is a bunk bed and a locker. It just makes it really tough to follow through on those appointments, that aftercare. All those things get tricky. And then also the fact that a lot of people we talk to will just talk about how they don't feel valued, they feel invisible, they don't get the attention that they feel like and that they do deserve being an elder. And so that comes into play as well. The stigma of homelessness, as well as some of the stigma that comes with age, and put those two together, it can really impact our clients as well. There's no guaranteed housing for seniors. This might be obvious to many of us, but oftentimes when we talk to the community, people are shocked that there's 80-year-olds in our shelter and that the safety net hasn't prevented that. But the reality is there's so many holes, and also less services with COVID, less staffing for home services. There's just things happen, and they do end up being homeless, and it's not a quick way out. There's no guaranteed senior shelter or transitional housing, which we desperately need. And then just the complex system. So we talked about sensory decline, and then we go into a system where we have to fill out 20 pages to get food support started, or we have to go through an online housing application. Things can get really difficult, and everybody really, I feel like every older adult needs and deserves a full-time case manager to really handhold and help them through those processes. It's difficult for us as professionals, often with college degrees, to get through a lot of these systems. And so if you just think about those who are without housing and have a lot more challenges, it can be near impossible to get through those without our assistance. Technology is also a big one, where we're helping people with their phones will get lost or stolen as well. So we do have a lot of older adult clients with smartphones, and some of them can navigate them really well and use their apps for rides and all different things. And some of them can literally only make phone calls with them. And then there's that added barrier of lost or stolen phones and having to replace them. So that's a constant battle. I will share a little bit about this gentleman on this slide. His name is Hamza, and he agreed to share his story with our program. He is an immigrant from Nigeria. He moved here in the 90s and raised a family here. He lived in New York for many years, worked full-time in security and taxi driving, and had made a pretty good life for himself here. Then moved to Minnesota. He was renting an apartment, and then he had some health issues and landed in the hospital. Because of that, he was no longer able to work because of his health conditions, and he just really had no idea where to start. He wasn't connected with public benefits or any case management of any sort. So he ended up losing his housing since he couldn't afford the rent anymore, and ended up in our shelters. I was lucky enough to be able to work with him and able to get him on some public benefits, some cash assistance that he was eligible for. And then get him into a public housing apartment, which was just the perfect fit for him. He loved it, but without assistance, it would have been really, really challenging to get through that, the whole system, the paperwork, the housing requirements. But he just loved his apartment, and then we were able to work with him on citizenship as well. So he really wanted to vote in the, I think it was 2016 election, and we got him his citizenship by the time that happened. So that was really exciting. And I'm sorry, I'm just going to pause one moment and get my lights to turn back on. Okay, there we go.
We do have a couple of questions that we can
Okay,
pop in.
perfect. Yeah.
One you've answered, but maybe you can talk a little bit more about it. And that's sort of with this new population, you are seeing elderly with more dementia or cognitive impairment related issues as well. Are you seeing more? Or is it the same, that kind of stream that you've always seen? Is it?
I would say in the past handful of years, probably the last 3, which kind of lines up with COVID too, I guess. But we've just seen an increase with the complex medical situations, people coming in with walkers and wheelchairs and oxygen tanks, and individuals that you don't even have to have a conversation to realize that they have some needs and some disabilities that aren't being met. So yeah, I would say recent, and we're not really sure what it is, but we can feel it as a team. And we get a lot more people who kind of will get calls from advocates at the shelters about clients who have just caught their attention as somebody who should not be in shelter, who has much higher needs than they can meet. And that's just happened a lot more recently.
And then there's kind of two other questions that are somewhat related. What's the definition of older adult that Catholic Charities uses? And then as you're talking about data and what impact does the shifting definition of, is an older adult 55 or 65, or is it a moving target? What impact, obviously, does that? It would have an impact on data in terms of how you can analyze sort of increases. Is it that the population is increasing, or
That's a
are
really
you
good
shifting
question.
your data?
And usually we have a slide of who is an older adult? What's the qualifier? So for all of Wilder's data, they consider an older adult 55 plus. For our program, we can work with people 60 and older, and that was kind of technically the DHS grant is technically for people 65 and older, which is the Medicaid or Medicare cutoff. But because people who are homeless age faster as well, their physical age is usually much older than their biological age as far as their health issues. We do have a few older, people in their 80s, but I think a lot of times people don't necessarily live that long when they are elderly and homeless too. So I think that's a factor. And that's why we're able to work with people down to 60, just because there's such a huge number of people, 55 plus really, but 60 plus is where we put the cutoff. Also, part of that reason too is because that group of people aged 55 to 61 before somebody's eligible for senior housing is just so big. And we could never meet the need for that. So we're always looking for additional programs and services for that age group. But that's probably the biggest number in general. Did that answer that question? I think I covered it.
Yes, I think so. There's a
More?
different question that just came through in the chat.
Sure.
If there are higher medical needs or needs they can't manage themselves, can they be hospitalized? And does the hospital help with placement? I'm guessing you're going to get to this. I know there's been that too is a concern, kind of
Yep.
long-term hospital stays for people who.
And I think I'm going to get to that in the next couple of slides, actually.
Okay.
Yeah.
Then I will stop, and we're good on questions, but people, please, put them in the Q&A, and Malia will get to them. We'll get to them throughout the presentation.
Thank you for that. So yeah, now we'll just get a little bit further into that whole point about increasing vulnerabilities and increasing challenges with the population that we work with. We just kind of discussed this a little bit, but the chronic health conditions, mobility limits, this gentleman here in the picture was using a walker, memory loss, the physical weakness, and oftentimes chemical use, as well as undiagnosed mental illness as well, a lot of times can complicate things. And so what we come across fairly often too is that we'll offer some services and offer some housing options. And a lot of times people are declining the assisted living or the nursing home placements because of the cost. So there's a few subsidized assisted livings out there, but they're pretty few and far between, and there's generally wait lists. So as far as something that's really viable and safe for somebody with a lot of health issues, like an assisted living, it's going to cost them most of their income monthly. And so we have a lot of people declining that. And so that comes down to the question of how do we serve those who really need a higher level of care, but they're not interested in what is being offered and where there's openings right now. This gentleman, I'll just briefly tell you his story. It worked out really well for him, one of our faster placements, I would say. Luckily, so he ended up also having some health conditions out of state and ended up traveling to Minnesota to kind of restart things and landed in our medical respite program. And that is a 12-bed program over in St. Paul at our St. Paul campus for those who are really too sick for shelter. but not well enough to, too sick for shelter, not sick enough for the hospital. So they'll end up spending a few weeks in respite. And this gentleman, Melvin, he came to us with a Section 8 voucher that was about to expire from out of state. So we were able to prioritize him, help him get into this apartment. Bridging did a lovely story with him. So they got some pictures of him with his new furniture as well. And then he was able to get waivered services in to meet those health needs that he had. So Section 8 vouchers are huge. That can really make or break housing options for people. But we do struggle a lot with people who are, we might be able to find some reasonable, what we feel is reasonable and safe accommodations, but that's not what people are wanting. And so that comes to the question of what do we do at that point? So we're working with a lot of people that struggle with self-neglect. Here's a laundry list of things that they're struggling with that we're trying to fill the gap and help them get through, and also help to get some services in place. But they're really asking for an independent subsidized apartment. So that's where more, if assisted living prices would come down, I think that would help the issue a lot. I know there's some work being done by our advocacy team with the legislature about lowering the cost for housing support to make it closer to 30% of someone's income, to make it more desirable, which I think would be huge. Because there's so many people that I work with that is they're just a classic example of somebody who really needs and could thrive with an assisted living program, and they're choosing not to. We do fairly regularly report self-neglect issues to adult protection as well, but they rarely, if ever, rise to the level of being investigated or being taken on as a case. So that's a challenge that we're dealing with. Hospitals, we often feel like discharge people too soon, but we understand the insurance issues and the too many people needing the beds issues, but we definitely struggle with that a lot. We get people discharged to our shelter so this is the interesting thing. We'll have people referred to our medical respite program. Our medical respite program will determine that they're too high need for that program because you do have to be independent with your activities of daily living. So bathing, dressing, transferring, all of that. So then a lot of times the hospital, if they get denied for the respite program, the hospital will still discharge them to shelter, which is not the best option. But also what are the other options? We really need we need a larger continuum of care for older adult senior housing. So, and adding insult to injury was just COVID the last few years. It's made things move at a snail's pace for the longest time. We were super excited when Social Security opened back up in person. I think that was in April, but it's still taking a long time to see people down there and get responses. So, and just staffing issues across the board have had a huge impact on our clients. Lack of face-to-face services. You miss so much with a telephone assessment for services. We're really hoping that changes soon as well. Any questions about that portion?
I'm reading through, some are put in the chat, so I was kind of reading through. I'm just making sure, see if they're just conversation or questions. How do you expedite Section 8 vouchers for subsidized affordable housing?
So there really isn't a way, although I will say that was a bit of a silver lining for us with COVID, because that there were a lot of emergency housing vouchers issued by HUD due to COVID. One thing interesting that I heard from the Hennepin County rep that was kind of distributing the vouchers. So for Minnesota, I know that those vouchers were distributed through the coordinated entry system for people who are experiencing homelessness. But I guess a lot of those vouchers across the nation didn't necessarily go to people who are homeless, but to people who needed who needed the voucher to maintain housing, which is a great use of it as well. But I was really glad that we were able to use those vouchers for people experiencing homelessness, and they did prioritize older adults for that. And of course, I mean, it doesn't need to be said, but we housed a lot more people when we had those vouchers to make rent affordable. So that would definitely be one solution that could really make a dent in older adult homelessness. Similar to VASH, we would love if the powers that be put as much energy into ending that homelessness, into ending older adult homelessness, although the issue is much, much larger.
Couple other things in the chat comments. One is an assisted living provider, just reminding us that there are some assisted livings who can who have like housing support contracts and can help. If people can't afford rent through assisted living, they can assist them applying through additional help through the county in choice, and so that can be an option. I don't know if you want to talk about that at all.
Yeah, well, so thank you for bringing that up. And I was really meaning that even with that assistance in place, people aren't wanting to do it. So with the housing assistance, let's say somebody makes $1,000 a month for Social Security, they'll have to pay almost $900 a month for that rent. And we might look at that and look at market rate rents these days and say, well, that is not such a bad deal. You get your utilities, your meals, some services through insurance, but people are still saying, nope, I want control over my money. I want to pay a lower rent. So that's kind of where we're at with that. But thank you.
There's a couple more, but I'm going to save them. I'm going to let you continue on, and then we'll come back, and I'll encourage people to go ahead and put any questions you want me to ask to Malia in the Q&A if you can. Sometimes they get lost in the chat, and then I don't know if they're answering each other. So
sounds good. Thank you. Let's see. So these are a couple of slides that I kind of feel like are just provides additional context for working with older adults. Just to point out, trauma is an issue that everybody that we're working with is dealing with, because homelessness is a traumatic experience. It kind of could be looked at as a lot of times trauma will cause homelessness, and then also homelessness is causing trauma as well. And in older adults, that can oftentimes look like other issues might be happening as well. So the memory problems, maladaptive coping, or maybe some negative behaviors, attitude change, loss of social support, avoidance, not wanting to engage, not wanting to talk with providers. It affects their mood. And then as well as information processing. So just thinking about the aging process on top of mental health and chemical health. And then it very well could be related to trauma as well if you're seeing odd behaviors or difficulty engaging. Mental health too, wanted to touch on that and how it can be a little bit different for older adults. Stigma plays a huge role with older adults in talking about mental health, getting mental health treatment, and mental illness is definitely a factor with a lot of individuals that we work with, and can make housing a challenge. Sometimes those symptoms could be mistaken for dementia. Something to keep in mind is a lot of times older adults will focus on the physical symptoms, so they might not, depending on what generation they came from, they might not identify with anxiety or depression, but they might identify with their nerves being frazzled or something like that. And then just the stomach aches, the headaches, the inability to concentrate, that can be a way that it presents a lot more often. A little bit on accessing shelter in the metro, and just kind of pointing out that it can be an extra challenge for older adults to navigate that system. Usually all of the beds are filled in the metro, and there's some sort of a lottery system or calling in just to see if there's a bed available, which can be very stressful. Most shelters will have people outside or at a different location during the day, so it's not a 24/7 shelter. There's very little storage for belongings. Medical equipment can be a challenge with that as well. I know with our newer shelters, we were able to put outlets by all of the beds, which is helpful for not only cell phones, but oxygen tanks or nebulizers. But if they don't have that, it can be really hard to maintain that health as well. And really, we just need more staffing. The larger shelters all shelters could use more staffing, but older adults would really benefit from a smaller environment, more staff there to support them, which is just something that we're mostly lacking. Although I do have one very small program to share with you that just started a couple of months ago. We got funding through Ramsey County. It was part of the kind of shelter redesign and planning what to do when the hotel programs shut down that were open for a while during COVID. And so through part of that process, Catholic Charities got some funding to change the old Pay for Stay shelter, which is just a smaller shelter space on the second floor of our main St. Paul shelter. Historically, it had been more for people. It was for people who were paying a daily rate to stay there. So they had more hours that they could be inside. It was a good program for people who might be working at night. But it hadn't been utilized much during COVID. And so we were able to change that into what we're calling the Focus Forward Shelter, which is, it's not completely senior specific, but it's geared toward people with higher needs. People who just aren't able to get their basic needs met in the main shelter as far as hygiene, medication management, rest. A lot of people just need more quiet and rest to recuperate and deal with their health problems. So we're able to open this 32 bed shelter. It's for men only because it's just one congregate space, but that is almost full. We're taking referrals from our main shelter and we're trying to move those with the highest needs up onto that second floor. We're hoping that we'll be able to get funding past this summer, but right now it's a short-term kind of pilot program, but we're very excited about it because we've been wanting a senior specific shelter or just more of a high needs shelter for a long time. So that's really exciting. It's a project, it's a collaboration between my program, the behavioral health team, which is a team of case managers that try to serve those with higher mental health needs at the shelter, and our medical respite program. So we're excited about that. Just a little bit about accessing shelter and the difference between the two metro counties. Hennepin County has an adult shelter connect. It's a one-stop shop. You can call a number, see if there's any beds available, and be assigned one if there is one. And then Ramsey County is a little bit trickier. They don't have that in place, but I know there's been some talk about getting something like that in place. But right now there's separate adult shelters and the way to access those varies. So it's a little bit trickier over there. And then Focus Forward is just directly through staff referrals. Any questions about shelter before I talk a little bit more about our program?
Well, maybe you'll talk a little bit about it when you talk about your program. There's one, are there at the shelters, do you have counselors on site, staff on site, or counselors, case managers on site? So if you could talk about that a little bit, that would be great. And then this, I don't know if you'll get to it or not. Did you have any older adults that were directly impacted by the Minneapolis taking down of the encampments? What was the impact of has the encampment removal been on your program or older adults?
So I'll start with that one. It hasn't really impacted our specific caseload. With us being such a small team, it's a team of 5 of us. We haven't been able to do a whole lot of street outreach, although we do occasionally get those referrals from the various street outreach teams. More often than not, we're working with people who are either in shelters or staying with somebody. So I don't have a whole lot of firsthand experience with that, although I do hope they change protocols and procedures with that. And then, I'm sorry, what was the first one? The first question.
Can you
support on site?
Yeah, counselors on site.
Sure. So I can talk about Catholic Charities. We have 2 large shelters, one in St. Paul and one in Minneapolis. Both of them do have clinics, healthcare for the homeless clinics right on site or right in the building, which is super nice. Other than that, as far as case management, we have a team of 3 case managers over in Minneapolis, basically with open-ended availability to work with people on housing. There isn't necessarily a specific group of people that they're focusing on, but they're available to start engaging with people and working on housing. So they'll work with older adults as well sometimes because there's so many, but we kind of try to triage the older adults to our team. And then over in St. Paul, it's a little bit more specialized around behavioral health, but it's our behavioral health team, which is headed up by a licensed clinical social worker. And then there's 3 case managers, and they're more focused on the high need, high mental health issues, kind of those specific individuals. And then of course there's other providers that come in kind of on a rotating basis from different agencies. But as far as Catholic Charities, that's mainly what we offer on site.
Is the Metro Shelter Hotline still a good referral?
That is a great question. I don't think so. I would recommend, I haven't used that one in a very long time. I would recommend Adult Shelter Connect for Hennepin, or probably United Way for other questions about shelter. So on to a little bit more about the Homeless Elders Program. So I've talked a little bit about us. We're a fairly small team. I definitely need to get an updated picture. Right now it is myself and then Danielle, who's standing behind me there. Our other 3 fabulous social workers have gone on to other programs. And so now we have 3 other individuals who are equally as fabulous. We do have an open position as well. So if you know of any licensed social workers, send them my way. But we've been around, we've had this Live Well at Home grant for about 8 years now. And it was really exciting. When I started with the program, it was just 2 case managers, one for Hennepin and one for Ramsey, which was a bit overwhelming as far as just trying to meet the need and work with referrals. So with this grant, we were able to expand our staffing, as well as starting to provide some trainings and education to the community, as well as our internal programs. So we've done a lot of training with our housing and shelter staff around best practices with working with older adults, and try to better equip them to get the services that our older clients need. We also have been working with housing stabilization services to supplement our funding a little bit. So we're excited about that. Medicaid service as well, where we're able to get reimbursed for some of our case management. Well, my clicker stopped working. Amanda, do you know how to forward my slide by chance? Oh, there we go.
On your computer, so I cannot help you there. Okay, you got it.
So mainly what we do in a nutshell is we work one-on-one with our individuals to get through those barriers and to get into housing. So we do a comprehensive assessment talking about housing needs, physical health, mental health, spiritual health. We try to take on a holistic approach with talking with them about what they need, and working together to create a goal plan and some steps to get there. We do a lot of housing research for housing placements, housing applications, and then a lot of follow-up with that, of course, as well. We do a lot of appeals. There's a denial for housing we always encourage people to do an appeal, because a denial might just be a bump in the road to getting into that apartment with some advocacy. Bridging referrals, we help people get set up in their new place with furniture. If not bridging, we look for other resources. So it's that Live Well at Home funding that we're able to provide the financial support to do bridging referrals, transportation. We can hire a moving company if they need to move things out of storage. Sometimes we can do a first month rent or deposit, kind of to get them settled in. And then from there, and that can take a long time. It can easily take a year or more to get someone into housing. But once we do, we also make sure that they're engaged with and connected with services to make sure that they stay there. So, and we're working on this from day one too, but just making sure that they are on medical assistance, they're getting all the benefits that they're eligible for. Are they eligible for a waiver? Is that going to help them stay in their home? Doing those referrals. We sit in on those waiver assessments more often than not, because that could be helpful getting that third party perspective as well on those needs. So it's really intensive case management. We have smaller caseloads of 25 at the most. We try to stick between about 15 and 20. So we can really take that time that each person needs to get to where they need to go. And just to reiterate too, it's all about connecting people, getting those support systems in place and making sure that they're well connected, getting those relationships built and warm handoffs to providers can really make a lot of difference. We also try to refer people to mental health services such as ARMS, TCM, and ACT, and other resources as well. So here's some questions that we just talk about with clients. There's a lot to it when we start a housing search. Every person is so different. We really need to learn about what they need and what they want and what's realistic. There's a lot of negotiating there, where some people will want a house on Lake Minnetonka, and that's not always an option. So it's coming up with what is reasonable and doable. Here's just a list of various housing places that we're looking at with people. So we're not just looking at senior housing or just looking at assisted living. We're really looking at different options. A lot of things through the coordinated entry homelessness system. They can be good options for people. Single room occupancy, permanent supportive housing for individuals where there's some case management on site, and those programs can be a little bit more flexible than your typical market rate landlord. Rapid rehousing is another housing case management program that we can get them connected to, and just a few other options that come up. And then the last piece specifically about our team is that part of the Live Well at Home grant also was to create a best practices manual for the community. So we made it was published in 2018. So there's a few things that could use some updating, but there's a lot of good information in there about different housing options, different mental health options for older adults. So if you're interested in that, it can be found on our website under the Homeless Elder program portion, but please feel free to email me and I can send you a PDF too. Or maybe I could just send Amanda a PDF and it would be good to send out with the PowerPoint slides as well. So I have a little bit more about COVID and maybe some ideas for system improvement, but maybe now would be another good time to stop and see if there's any other questions.
Lots of questions. So first of all, are there programs like this outside of, and we're getting several greater Minnesota questions. So, and then do you only do this in Hennepin, Ramsey, Minneapolis, St. Paul? So,
right, yes. Yeah, we only cover Hennepin and Ramsey County right now. I'm not really aware of any other specific older adult case management programs in the state. I know there's another program up by Detroit Lakes who was working with older adults, but it was more housing specific. Our hope is that HSS will fill some of that gap, just to have more housing case management in general. I think it's way too difficult to get a case manager to help people with housing, but I'm hoping the HSS continues to develop and improve and be that. And we're always looking for ways to expand our program too. seems to be very little funding out there for homeless older adults specifically. But we're always looking for ways to expand and cover more ground as well.
So what is your service area that specifically, and then how does someone refer into your program?
So it's Hennepin and Ramsey counties.
Okay.
As long as they are in one of those two counties and are age 60 or older and currently homeless, then they would qualify. I can send you a referral form as well. I would warn you that we have a bit of a wait list right now, a few months before we'd be able to really work with somebody one-on-one, which is why we need 3 times the size of our team. But yes, I can send along that referral form as well.
What is the time frame that someone could expect to receive services from your program? So it sounds like it would even just to get accepted, you fill out this
Yeah,
form, and then it takes a couple months, you're on a wait list.
I would say 3-4 months these days. Yeah.
And then I'll just let everybody know I'm the PDF that everybody wants, we are going to send that out to everybody. So you're going to get it. So, and then the forms that Malia is talking about. So, yep, you'll all get it.
And you know what, and we're always happy to consult with you too, if you have somebody that you're working with, just to maybe get some ideas or get pointed in the right direction.
Is there a number that people can call? They can find this on your website to reach you?
Yes. Yep, I think our intake line is on the website. Otherwise, my phone number will be on the end of the PowerPoint too.
Okay.
So you can reach out to me.
Does Catholic Charities through this program provide HSS services?
We do. Yep.
Mhm.
Yeah. So we are an enrolled HSS provider. And then we try to refer out. We're actually going, I think one change we're going to try to make this year is try to do more HSS referrals as well, maybe for individuals on the list who aren't as high need, who might need more of that traditional housing search, but where we might be able to do that consultation and refer them out to HSS. That's also something, to a different HSS provider. It's another thing we're looking at.
So if there's a 3-month wait to get onto your what is to get services for you, what's the recommendation for what can people do in the meantime?
Well, HSS is one thing. I could send out some housing resources too. We use Housing Link a lot to find low cost apartments. And care app. Well, I guess it depends on what the situation is. I could point you in the direction of some different housing search places for different types of housing. So yeah, every situation is so unique. It's hard to give general advice on that, but reach out if you have questions.
I'm still working through the Q&As here. I want to make sure that we have 7 minutes left. I want to make sure what other information you want to make sure that we leave here with. Otherwise, I can keep on asking questions.
So I'm glad I have more material than less. We have a couple slides here on COVID that I thought would be interesting, but also I'll leave that to you to look into later if you'd like to. Because I think now would be a good time just to go over these last couple slides. So here's some things that we've learned overall, that there's a significant gap in available and appropriate housing to really meet the needs of our older adults. One-on-one case management is so critical. I think that makes all the difference. And I wish we had enough case managers for everyone. Clients without the ability to make sound decisions are allowed to do so in the name of self-determination. So we just run into that a whole lot with the self-neglect and working with adult protection and understanding the parameters and restrictions around that. And it just feels like all too often people really without the capacity for decision making are able to and suffering as a result of it. And also it just, in this line of work, oftentimes it feels like society as a whole, because of the way systems are set up, it feels like we're okay with vulnerable older adults being homeless and on the street because there isn't a solid support system to support them.
So there's a question in Q&A that's a little related to that, and I think how proactive or how can your team help in terms of, working with someone with serious illness conversations, advanced care planning? Are you working with, folks from the Center of Excellence and Supported Decision Making or Lutheran Social Services to do supported decision-making plans,
We
guardianship tracks? How engaged, how much are you able to kind of dig into those issues when you're trying to get somebody housed?
so
And
we do with our, I would say, most ill individuals, those who are really struggling and might have common things that really throw people off are delusions, paranoia, things like that. And it's been a challenge. We have been able to get a few people set up with guardianship over the years, and then quickly learn that guardians have a lot of limitations as well and very high caseloads, and a guardian can't make anybody do anything either. So it can be very challenging. We've seen, I think, a couple short-term commitments in hospitals to kind of get people stabilized. We have, I know one of our clients was at the point where she was interested in wanting a guardian, and I think it was Lutheran Social Services. It was one of my staff, but she was able to get her connected with the guardian voluntarily, which was refreshing and a good result. But it's a constant challenge and constant conversations that we're having in team meetings, how to best support those individuals. And we're always open to more ideas too. I think there needs to be more collaboration too with those teams. And that's just what we have on these last couple of things too, just more need for people, in-person, multidisciplinary teams. I know funding is an issue. If we could get more funding to fill that gap between hospital and home, I think there's a gap there too. So with that, we can open it up to any more questions or discussion that we have. We also just want more low barrier assisted living and supportive housing. That's what we're really seeing the need for.
Can you talk, here's a question, can you talk more about the medical respite kind of process or problem? When someone wants to know, is this like a, transitional care unit with rehab services, or is the only way to use a respite program is by being discharged and transferred from the hospital? How long
So
does someone stay? Can you talk about that?
So for our program in St. Paul, it is they have a contract with, I think, 3 specific hospitals in St. Paul that will refer people, and they provide nursing coordination. So they help with medication management, but they don't have direct care there. They do have a nurse and a mental health professional. They can do some assessments and referrals, but their main goal there is to help somebody follow through with their aftercare and get them onto appropriate services. Usually it's only a stay of a couple of weeks. That's about all the hospitals are able to pay for. So it's a short term, really hard to secure permanent housing, although that can happen in that amount of time. But I think it'll be really good to have this additional focus forward shelter where it's maybe a kind of a step down from respite, but a better environment than our large congregate shelter for individuals. What else?
See if we can get another one in here. There's a couple questions here about, and see if we can tackle that. I can help a little too about the role of APS and especially when with self-neglect. Can you talk about it? I think you stated early on that you were working with APS in certain counties on some of that. Can you talk about what you're working on and your experience? In 1 minute, and then we'll close this out and we'll send everybody slides in the recording.
I will say our work, it's really more working one-on-one with the individuals who are investigating the situation and trying to collaborate on solutions there. We would really like to be more involved in, I know some consultation meetings that they have, and we kind of just started to get more deeper into that with the start of COVID, and then things were put on hold. So we'd like to get back to that and further develop that collaboration piece. But right now it's more case by case, staff by staff.
And self-neglect is one of the highest sort of case reports that APS throughout the state gets. And they are some of the most, difficult. It's very difficult to work with, as we all know, everybody on here,
Yeah.
working with individuals who are experiencing self-neglect.
Options are limited.
It does not mean we don't continue to work to support. It just means it's limited. All right, thank you to everyone who participated today. There were a lot of you on here. Thank you to Malia for this. I know that we could have gone longer, and we can certainly look at having doing more conversations around homelessness and older adults and vulnerability. Again, thank you for participating. We will send out the slides. We will send out the additional PDFs, as well as a survey and CEUs. Thank you, everyone, for participating.
Thank you. Take care.